need to consult the urology first before proceed with any catheterization for this patient. He was given regular analgesia for the pain control, started on IV maintenance for the fluid. He was kept kneel by mouth for preparing him for any emergency procedure in OT. Anti-tetanus was given. IV unacin was started for this patient. He then was referred to surgery and urology team for further investigations. CT abdomen and pelvis with contrast was proceeded for this patient in emergency department. After that, the patient was admitted to ward under urology team. This is a summary of the blood investigation for this patient. Upon arrival, the hemoglobin is 14, with the total white slightly raised is 21.8, with normal platelet to 170. The renal profile is normal, except the creatinine slightly raised is about 115. So the summary of radiological imaging done in emergency departments, we started with the bedside fast scan, which noted a minimal free fluid in vesical rectal junctions. We also proceed with the X-ray of the left hip, and after discussion with the urology department, we proceed with CT abdomen and pelvis with contrast at the time of patient arrive. According to patient history and physical examination, our ED provisional diagnosis is throughout the urethral injury. Other than that, because we still unable to rule out other few injury like the bladder injury, prostate injury, and rectum injury. So after this, we will proceed with a discussion with Dr. Erika, our radiologist, to discuss regarding the finding of the CT abdomen for this patient.
Dr. Erika.
Hi all. Yeah, thanks, Nakib. So I will proceed with this explanation on some of the radiological examinations done in this patient. All right. So a left hip X-ray was done on presentation. Presumably, the indication was to exclude any radio-opaque foreign body that might be left within, and pelvic to exclude any pelvic bone fracture. So in this case, we have a anterior posterior view and also a lateral view of the left hip, which did not show any significant fractures or any foreign body seen. In this case, if you don't have suspect of any of these, or you have already have a plan to proceed with CT scan, then this X-rays is actually not really necessary. Okay. So after that, a contrast enhanced CT abdomen was done. The indication was because the patient presented with hematuria, and so injury to the urinary tract is suspected. And also because no one knows how deep the penetration went, so pelvic organ injury was also suspected. So it was done for those reasons. Right. So this image here shows us a sagittal view of the pelvis, only the part of the pelvis, because the upper part was imaged but was cut off. This is a very distended urinary bladder, but you can tell that the outline is very smooth. Okay, there was no irregularity or focal defect in the urinary bladder to suggest any penetration or any injury to it. And there is no fluid around the bladder that will suggest to us that there is leak from the bladder. So the bladder is most likely clear in this case. This is the prostate area, and below it, over this part, you can see a soft tissue tract, linear tract coming from the left inner thigh, going all the way. This is the area just beside the bulbous urethra area, the penile bulb area. Okay, so it leads to that area, and you can see some air pockets. This is the asterisk where the air pockets lying alongside the soft tissue tract. So this soft tissue tract represents the tract where the metallic object actually went in through. All right, and The next image shows us the perineum view, perineum region in axial view. So this enhancing structure here is the corpus spongiosum, and the muscle immediately surrounding it is the bulbocavernosus muscles, and the one that runs along the side and inserts into the ischium is the ischiocavernosus muscles. So in between these two muscles, this fat space here is called the urogenital diaphragm fat plane. All right. So normal one should be like this on the right side, but over here you can tell that there is a soft tissue density or a collection sitting right between the bulbocavernosus and the ischiocavernosus muscle. So when there is a collection sitting there, we have to suspect that there is a posterior urethral injury because it's very near to the urethra. And this is the anus here. Although the collection also sits quite near to it, but the sphincteric muscles are all intact, as we can see from the different layers of the anus that is demonstrated on anus. So although it is very near, but there is no evidence to suggest any injury to the anus or rectum, which is slightly above it. And slightly superior to the slides just now, in the lower pelvic region, this is the prostate. P is the prostate here. And the asterisk shows the fat space, the pre-prostatic fat space, which is supposed to be almost completely black like this. So over here, you can see a little bit of stranding, but on the right side is completely obliterated. These fat spaces should be symmetrical. In this case, there's a soft tissue density sitting here, right in the fat space, which is most likely a hematoma. This is also an indicator for possible urethral injury. Not always there, but you have to suspect when this sign is present. And then this is further up in the lower pelvic region, in the lower abdominal region where you can see the bladder already. So again, it demonstrates a very smooth bladder outline without any fluid surrounding it to suggest there was no signs to suggest bladder injury. And the small dots running alongside is actually the distal ureters, which are filled with contrast in this case. So when we trace the entire ureter also, there was no signs to suggest any injury to the ureters. Yeah. So the rest of the review of the images excluded any injury in the rectum, in the other organs, in the pelvis, and yeah. So the impression would be a suspicious posterior urethral injury based on the obliteration of the pre-prostatic fat plane and also the urogenital diaphragm fat plane. So after this, the urology assessment opinion comes in. Yeah, I pass to Dr. Koo now.
Thank you, Dr. Erica. Dr. Koo?
All right. Very good morning. Thank you, Dr. Ida and the ED team for inviting me to make a short presentation on the assessment and as well as management of the urethral injury. And thank you, Dr. Erica, for the good explanation on the CT scan. That will make the explanation much easier. So I hope everyone can see my screen. Is my screen visible? Yeah.
Yes.
All right. So I'll be talking along the line of urethral injury in this case. The outline of my presentation will along a little bit on anatomy. This is mainly to explain to the medical students as well as newly graduated housements of medical officers around the anatomy of the urethral. A little bit of epidemiology, etiology, how we evaluate, and the immediate management as well as the definitive intervention for a patient with a urethral injury. All right. So this briefly is the anatomy of the urethra. So in a female, if you can see, out of the bladder, the urethra is actually very short. All right, and then they're surrounded by a lot of fat, and vagina is behind it. So because of the short urethra, a relatively mobile and flexible structure of the female urethra, the risk of a urethral injury for a female patient is actually very low. So that's why you don't see a lot of a urethral injury in a female patient. However, if you see in a male patient, you can see that the urethra extends from the bladder neck. It's actually a very long structures out until along the penis until the urethral meatus. So because it being a long structure surrounded by a lot of rigid structures such as the prostate, the pubic symphysis, and the penis with the cavernosus surrounding it. So the risk of injury is actually higher compared to female. So that's the reason why we get more male urethral injury compared to a female patient. All right, this is another view to differentiate what is actually the anterior urethra and what is the posterior urethra. So as Dr. Erica mentioned just now, this patient actually has a posterior urethral injury. So it's actually quite important for us to differentiate between anterior urethral injury and posterior urethral injury because the management will differ, right? So the anterior urethra will make up where the meatus is, the fossa navicularis, the penile urethra, the bulbous urethra. All right, so this will be the anterior urethra. And when we go towards the membranous urethra, the prostatic urethra, and the bladder neck, this will be the posterior urethra. So just keep this in mind, where the cutoff point is at the membranous urethra. All right. So how many cases do we see actually? All right. So as I mentioned earlier, male patients would be predominantly the cause of the urethral injury. And guess what is the most common cause of urethral injury? Is catheterization. All right. So we, the healthcare workers, are the one that causes the most urethral injury. All right. A report from the Europe shows that up to 13.4 out of 1,000 urinary catheter is the cause of urethral injury. So imagine 1 in 100 catheter that you put, there will be some urethral injury. And commonly, this is because of false passage or balloon inflation within the urethra. So that's why it's very important for me to stress here that when we insert a urinary catheter, please make sure that we insert it a proper technique, make sure it's sterile, make sure we do it gently, make sure we do it right so that we can avoid all this urethral injury. But then when we come to trauma, other causes will be blunt injury, usually when they straddle injury, like, they ride a horse, they ride a motorbike, they hit the perineal region, or they got kicked at the perineum. So that will cause the urethral injury. Penetrating injury is very rare for anterior urethral injury. And finally, foreign body insertion. This is either a psychiatric patient or patients with autoerotic where they insert foreign body into the urethral meatus. Posterior urethral injury, meanwhile, is commonly associated with pelvic injury. So it's usually motor vehicle accident, they got pelvic fracture, so they lead to this thing called a pelvic fracture urethral injury. Penetrating injury, like the one we see in our patient, is actually rare, right? It's actually very uncommon in a civilian setting. So in the West, it's usually gunshot injury, but when it's gunshot injury, usually it's associated with some other injury as well. And then, like in our case, it's a fall trauma where the metal rod hit into the perineal region. All right. The thing about posterior urethral injury is actually often more life-threatening injuries that you need to pay more attention, like rectal injuries, pelvic fracture. So usually the urethra will be very low down the list of management. In female, blunt injury, again, is because of pelvic trauma. Rarely can be because of birth injury, where they tear the vagina and the urethra as well. So how do we evaluate patients? So these are the common signs. The most commonly what you see is blood at the meatus. That means patient is not passing urine, but you see blood at the meatus. And if you see that, please be suspicious that this patient might have a urethral injury. Another one is a patient unable to void and with a distended bladder. So as you see in our patient, the bladder is very distended. So there will be some form of urethral injury. Other causes will be like haematuria and dysuria. These patients, usually they can pee and they get haematuria and dysuria because the injury is partial. So the urine can still come out. There will be pain, there will be blood, but they can still pee. Next will be penile, perineal, or scrotal swelling or scrotal bruises. Don't have a good picture on this to show you, but technically, if you examine a patient with motor vehicle accident, and then you see there's a lot of scrotal hematoma, a lot of perineal ecchymosis, please be worried that you have a urethral injury. High riding prostate, not a very good sign, but it also can significant the presence of urethral injury. In the ladies, blood at the introitus, any labia swelling, vaginal injury, suspect the presence of urethral injury. And because the close proximity of the urethra as well as the rectum and the vagina always suspect the presence of rectal or vaginal injuries. So what do we do to assess whether there's possibility of a urethral injury? Two things that we can do. One is a retrograde urethrogram. So we put in a small catheter at the tip of the meatus or inside the fossa ventricularis. We inject about 20-30 cc of contrast, and then we take X-rays. So we can see whether the contrast fill up the urethra and goes into the bladder. So I think Dr. Erica will explain about our patient later, so I will skip here. Next will be a flexible cystoscopy. So this is what we do. What we do is we put in a camera, we put in a scope, and then we go in and see, all right, to see what is there any injury, whether it's a complete transection, whether it's a partial injury, a mucosal injury, so we can see. And the additional advantage of this is we can actually put, if the injury is partial, we can easily go into the bladder. We can actually do a guided catheterization. So we put in a wire into the bladder, we put in a catheter in. Other imaging that we can help is ultrasound. The role of ultrasound mainly is to help us to guide us where is the bladder, so we can do a suprapubic catheterization. Meanwhile, MRI is mainly for complex injuries. All right, so what will be our immediate management, right, when we see this type of patient? Okay, so first we talk about male because this is the most common. All right, in an anterior urethral injury, as we mentioned earlier, anterior urethral means is where the meatus, the fossa navigularis, the penile urethra, and the bulbar urethra. Okay, so in patients with penile fracture or a stable penetrating injury, usually we will go in for immediate exploration and reconstruction. Because the injury is usually, because in penile fracture, we need to repair the penile fracture, so we repair the urethra as well. In penetrating injury, if they are stable, usually we will debride and we will repair in the same setting. But in blunt injury, it's not so straightforward. So blunt injuries are, as I mentioned just now, it's like you got straddle injury, you got kicked in the perineum. So in this type of cases, the long-term outcome is actually similar between immediate repair and deferred repair, but it must be done in a center with a dedicated urethral surgeon. You must have someone who is repairing the urethra every week, must be experienced in it. Otherwise, we will consider either a transurethral or a suprapubic bladder catheterization for urinary diversion. All right, so this is like an example of a SPC we put in and the suprapubic catheter. The reason why in blunt injury we don't do immediate exploration is because sometimes it's very difficult for us to know how bad is the injury. There will be a lot of bleeding, a lot of edema, there's a lot of contusion on the spongiosum. So we will sometimes overestimate. So we will actually cut more than needed. Ended up we have difficulty to attach both the urethra together. So we don't usually do that. Meanwhile, in posterior urethra, which is you're talking about the membranous urethra, the prostatic urethra, is always, sorry, not always, is usually associated with more severe injury. So remember always to treat those first. This is the least priority. So usually in that setting, what we aim for is to achieve urinary diversion. So we either do an ultrasound guided or open SPC. Open will usually done in the OT. When they go into the OT for external fixation or is laparotomy, we will do an open SPC. Or we can try to do a transurethral catheterization, usually with a cystoscopy. All right, but it's actually, we can actually try a single attempt, one single attempt by an experienced personnel with plenty of lubrication. We can actually try one attempt to put in a catheter. The reason why is because a single attempt will not make the injury worse than ever, but it must be by an experienced personnel. You cannot ask a junior member to just come in and put in a catheter without adequate lubrication. It will cause more injury. But if it's an experienced person, a very well experienced person to do it, it's actually okay to try one single attempt without a cystoscopy. All right. But if there's a bladder neck or a prostate involved and the patient is stable, usually we will consider early repair. In female, it's very similar to male, so nothing much to talk about. Always treat the life-threatening injury and aim for urinary diversion. So what we do for this patient, so technically we did a cystoscope. I don't have a picture with me because when they did the cystoscope, we didn't take any picture. We practically noted injury proximal to the penile urethra. So we unable to go further from the penile urethra into the bulbar membranous of prostate. So we can't really tell where exactly is the injury. And there's a lot of blood clots noted. We cannot find the lumen into. So we decided not to proceed further because it might cause more injury. So we just do a suprapubic catheterization. All right. And then once the patient improves, then we plan for ascending and descending urethrogram to know the extent of the injury. During the assessment, we actually did a digital rectal examination by us as well as the general surgical team. We don't see any palpable rectal injury. There's no blood coming out from the rectum. So we don't think there's a rectal injury. And for the wound, because it's clean, we just treated with antibiotic and dressing. We didn't proceed with any wound debridement. All right, so I think I'll pass back the floor to Dr. Erica to talk about the ascending and descending urethrogram. So the reason we do this urethrogram is to plan for our definitive intervention after this. Thank you.
Thank you,
Thank you, Dr. Koo. Thank you, Dr. Koo. So I will continue with, the ascending and the, or another name for it is retrograde urethrogram done 2 weeks later. The indication was like what Dr. Koo mentioned, to assess the exact site of injury because they couldn't see it in the cystoscopy and the type of it. Okay, so this is the image showing the ascending phase of the ascending urethrogram. So you see the balloon here in the fossa navicularis, okay, the tip of the Foley catheter. And this is the SPC, the suprapubic catheter that was already in, and the balloon of the suprapubic catheter. So during ascending phase, we inject contrast. So the contrast actually starts to fill the penile urethra first, and then the bulbous urethra. The membranous urethra will be somewhere around here. And this is the prostatic urethra. So this filling defect here is an air bubble, which eventually is pushed up and went into the bladder. But in this case here, we see the posterior or the prostatic urethra to be slightly irregular. The caliber cannot be assessed on this phase because most of the time the pressure is not enough because the pressure comes from the meatus. So the pressure may not be enough to distend the posterior urethra properly to allow a proper assessment. But in this phase, we could already tell that the contrast actually leaked out from the area between the membranous and the prostatic urethra. This is already contrast extravasation where the arrow is pointing to. So the point of injury is most likely at the lower prostatic or the membranous part of the urethra. And because this contrast actually comes from the SPC, yes. So before the bladder filled up, actually we could demonstrate that the contrast went into the bladder. So it tells us that this is a partial injury, not a complete disruption. And this second image here shows the miturating phase. We always complete an ascending urethrogram with a miturating phase because only during mituration, the contrast is being pushed into the posterior urethra from the bladder. So the pressure will be big enough to allow a proper distension of the posterior urethra so that we can properly assess for any contrast leak or any stricture, okay? So in this case also, we see again the contrast extravasation coming out into the anterior to the part of the prostatic urethra. So, and over here, the anterior urethra is again demonstrated and is normal. So there was no contrast coming out around the bladder. So again, ruled out any bladder injuries. Okay, so the impression from this ascending ureterogram is a partial prostatic or membranous or around the junction between them urethral injury evidenced by contrast leak coming out from there. And the long segment narrowing and the irregularity of the prostatic and membranous urethra suggests that there is a possible contusion or formation of an early stricture. Yeah. So a little bit about the role of imaging in urethral trauma. The study of choice in diagnosing and locating urethral pathology remains to be ascending ureterogram. Okay, this is the gold standard. So the indications, not only in trauma, but other things like urethral strictures, urethral diverticulum, fistulas, or post-operative evaluation of the urethra can be achieved through ascending ureterogram. And there are no absolute contraindication, but some relative ones are, if the patient is unstable, you would like to consider stabilizing them and investigating for other more severe injuries that causes the hemodynamic instability instead of doing this ascending ureterogram, which is not really that urgent, okay, compared to other life-threatening conditions. So this is a relative contraindication. Contrast allergy, this can be covered by prednisolone and steroids, okay, if really the indication for this examination is urgent. And acute UTI, urinary tract infection is because we are injecting or we are putting in catheters. And so in acute urinary tract infection, we would like to avoid that. So this is a relative contraindication. So as I have mentioned just now, ascending ureterogram consists of two phases. One is the ascending phase, and one is the descending or the mituration phase. So the ascending phase, the main purpose is to assess the anterior urethra. So in this case, we are looking for injury, okay? Anterior urethral injury, the penile and the bulbous part. And then the mituration phase primarily looks for posterior urethral injury, any injury in the prostatic and the membranous part. So bladder filling usually is achieved slowly through the ascending phase, where you just push in the contrast continuously from the fossa navicularis region. Or if you want to be faster, and if the patient has an SPC, then it will be much faster to inject through the contrast through the SPC and fill out the bladder for patient to pass urine. But we have to remember that we should not advance the Foley catheter, which is in the fossa navicularis region. We should not advance that further from until urethral injury has been completely excluded. So usually we don't advance it in any cases with injuries with trauma. So ascending ureterogram can tell us whether this is a partial disruption of the urethra or a complete disruption. So if you can see contrast going up beyond the site of the extravasation, that means the urethra is actually in continuity, and it will tell us that it is partial. But if, let's say, after the contrast extravasation, there was a loss of urethral, there was lack of proximal urethral opacification, that you cannot see the part of the urinary tract, urethra or the bladder filling up, then it tells us this is completely disrupted, okay, which will differ in management as well. So, and the ascending ureterogram can be repeated later to diagnose post-traumatic urethral stricture or fistulas. CT scan is excellent for imaging the upper urinary tract, which includes the kidney and the ureters, and also look for any bladder injuries, as what I have shown you just now. So they are very good and almost can exclude if it's normal. And the CT scan at the same time can also look for any pelvic fractures, okay? So that's the plus point about CT scan in traumas. For urethra, it is not as good in assessment because most of the time there will not be any contrast within the urethra to distend it and to allow proper visualization of the entire urethra in CT scan. So like the patient just now, unless the patient is miturating, there will not be any contrast within the urethra. So on CT scan, we rely on indirect signs to suggest whether there is any urethral injury. So like the signs like obscuration of the urogenital diaphragm fat plane, like in this patient, okay, it was obscured. So in 88% of patients who have this sign, they were proven to have a urethral injury intra-op. Yeah, so this is quite an indicative sign. Or obscuration of the prostatic contour, this patient also has it. So in 59% of them, they were proven to have a real urethral injury in a study. So this sign is not a very sensitive sign, I would say, compared to the obscuration of urogenital diaphragm. Other signs like hematomas of the ischiocavernosus muscle, bulbocavernosus muscle, and obturator internus muscle were not actually present in this case. So there was no hematoma seen in the muscle. And CT scan may serve as a screening tool for urethral injury in polytrauma patients who require CT scans. Yeah, because you have to do the CT scan for polytrauma assessment. So at the same time, you can actually screen for it by looking for all these indirect signs. Okay, so CT can actually demonstrate direct signs if in some cases the urethra is actually filled up with contrast. So then they will directly show you the site of injury and also contrast extravasation from the site. MRI has no role in acute trauma, okay? So please don't ask for MRI in acute traumatic situation, but it has a complementary role in preoperative planning in complex cases, okay? So it can look for prostatic displacement and it can precisely measure the length of the posterior urethral defect and the degree of the scarring around it to aid in surgical planning. So conclusion, for imaging part, ascending ureterogram is the gold standard in diagnosing urethral injury. CT is excellent for renal, ureteric, and bladder injuries, but it is not as good for urethra. Okay, it may serve as a screening tool for urethral injury in polytrauma cases when the CT is actually more indicator for the rest of the injuries. So with this, I pass back to Dr. Koo.
Thank you, Dr. Erica. Very informative. Yeah, Dr. Koo. Dr. Koo, I think your microphone.
Okay, now can you hear me?
Yes.
All right. Okay, so now we know that this is a posterior urethral injury. So now we have to start planning what is next for this patient. All right, so we're going to talk about definitive treatment. All right, so definitive treatment for all this urethral injury is eventually urethroplasty. All right, so urethroplasty is technically a surgery where we open up, find the urethra, and then we either cut and anastomose or we put some graft on top. So this is all the form of a reconstructive surgery. It can be either done early, between 2 days to 6 weeks, or it can be done later after 3 months. Okay, so when do we do early? Technically, there must be a few criteria to achieve. The patient must be stable, the defect is short, perineum is soft. Soft means there's no hematoma there pressing on the perineum, so we cannot operate. Patient must be able to lie on a lithotomy position. And if the bladder neck or prostatic urethra involved, is actually best done during this time. All right. But if these criteria cannot be fulfilled, then it will be a deferred urethroplasty, and it's usually after 3 months. So this is actually the standard treatment at this moment. Why we wait until 3 months? Well, technically we want to wait for the hematoma to resolve, all the scar tissue has stabilized, they don't form new scar tissue, all right? And post-state, because of all the edema, the hematoma, they resolve, they move back to the normal position, and patients are usually stable by then, and they can go on lithotomy position. And usually we can achieve up to 86% success rate with a good continence and sexual function. Why we say in early, we say 2 days, because within the first 48 hours, as I mentioned much earlier, there will be a lot of bleeding, a lot of swelling, there will be a lot of blood loss during the operation. And even with the operation, there will be high risk of incontinence and impotence. So usually we don't do it in the first 48 hours. All right. So some of the pictures I can show you, this is not my picture. Technically, we operate through the perineum. So this is the penis, the scrotum, and the testis is lift upwards. So this is where the penile urethra and the bulbar urethra is before going into the membranous urethra. So this is how we access into the urethra. And then depending on the injury, let's say the injury is short, what we can do is we can cut and anastomose. So it's just a primary anastomose of the urethra. But sometimes when the injury is very long, this is a penile urethra injury where it's very long, then what we do is we take buccal mucosal graft. So we take a graft from the buccal mucosa, and then we do it as part of the urethroplasty. So these are some of the examples. Next will be another way we can do it is endoscopic realignment. This is mainly for partial injury. Rarely we can do it for a complete injury. So what we do is we put in a cystoscope like what we did just now. And then if we can find the lumen into the bladder, we can put in a wire, confirm it with our image intensifier. We can guide our scope in. We can put in our urinary catheter. So this is considered in stable patient because it takes some time to do it. It's not that easy, just put in and just go off. So in stable patients, we can do it. The reason why when we put in a catheter like this, it can reduce the extravasation of urine. It reduces the inflammation. And let's say this is a complete transection, and because it's transected far away, sometimes when we do this, we can realign it back so that the straight line is better rather than go far away. And usually once we do it, we put in a catheter, we leave the catheter there for about 3 weeks in the partial injury and 6 weeks in the complete injury. The benefit of this is, number one, we can reduce the stricture rate. And even if they develop a stricture, the strictures are usually shorter. So when it's shorter, it's easier to treat. We can either do an endoscopic intervention, or if we need to do a urethroplasty, we don't have to use mucosal graft. We can just resect and anastomose. In female, it's slightly different. So in female, usually we aim for early repair, right? Usually within a week, we need to repair. So usually once we stabilize the patient, there's no other life-threatening injury, the patient is stable, we go in for repair. The reason we do this is because it's less complication, and the exploration and repair is usually short, usually because the urethra is short, easy to primary anastomose. And then if there's any associated vaginal injury, we can repair it the same setting. We try not to wait more than 7 days because when it's more than 7 days, there's a lot of scarring happen. The reconstruction become a bit more complex, and it will lead to higher risk of incontinence as well as vaginal stenosis. We don't try realignment in ladies because the urethra is already very short, and any realignment actually just results in higher rate of stricture as well as fistula. All right. So in this patient, we know that this is a posterior urethral injury, and we probably need some form of complex intervention. So for 2 reasons, one is a financial reason as well as the need for a specialized reconstructive surgery. We referred to this patient to a reconstruction center so that they can do a better job, especially in a posterior urethral injury. So haven't gotten the feedback what happened to this patient. So in the meantime, the patient was on an SPC for urinary diversion and probably awaiting the surgery for it. So this is just a baseline algorithm for anyone that is managing a patient either in ED or when you have referrals for urethral injury. So first we need to know whether it's an anterior or posterior urethral injury. So it's anterior urethral injury, as we said, iatrogenic is the most common. Usually if there's IIG injury, you can put in a catheter, you just keep the catheter there. All right. Usually within 2 weeks, it should heal. If it's a concrete transaction, you might need to wait 3 weeks and repeat a ureterogram. But if it's a penile fracture or penetrating injury, and the patient is stable, it's immediate repair. In blunt injury, it depends, all right? So technically, if it's blunt injury, you are in a center where they repair urethra all the time, you can go in for immediate repair. If it's not, usually it's diversion, all right? Then we see what happened, okay? So diversion is either a urethral catheter or a SPC. In posterior urethral injury, it's a little bit more complex. So first, you must know whether the patient is stable or not stable, because it's usually associated with some form of pelvic injury. If it's unstable patient, resuscitate an SPC, all right? No need to think about any other repair, okay? So you can either try one time of catheterization, as I mentioned, someone experience a lot of catheterization, just a single attempt is okay. If not, SPC, either ultrasound or SPC guided. But if the patient is stable, so you can do a retrograde ureterogram, like what mentioned by Dr. Erica, or we can do a flexible cystoscopy, all right? So we can see whether it's a partial or a complete injury. So if it's a partial injury, we can try realignment. If we cannot realign, then it's going to be SPC, and then we follow up. But let's say if it's a complete injury and there's injury to the bladder, neck, and prostate, immediate repair. But if there's no, then we can see whether the patient needs any other injury, like an external phalanx, laparotomy. We can either try early endoscopic realignment or we can try SPC. And depends on the patient, we can either do an early urethroplasty or not. It's going to be a 3 months urethroplasty. So this algorithm is easily accessible by the European Association of Urology guideline. So anyone want to look at it in detail, you can have a look at it. All right, I think that's all for me. Thank you very much.
Okay, thank you very much, Dr. Koo, Dr. Erica, and Dr. Nakib. I think what we can conclude from this topic, basically, it is very important for every trauma patient. We need to know the mechanism of injury. And of course, we need to relate with our clinical findings, the clinical features, and pertaining to the possible GU trauma or specific urethral injuries, basically blood at the meatus, urethral meatus, and of course, tenderness per abdomen, and of course, plus unable to void is very important details to tell us regarding the possible urethral injuries. I think for now, it is very important from the Dr. Erica and Dr. Koo information, so that our MOs in ED can understand better regarding how to diagnose urethral injuries, and of course the management, acute management and long-term management of the possible urethral injuries. I think I wait for the question from the participant. If there is no question yet, what I can say further about this topic, let me recap. For the urethral injuries, it is not a life-threatening condition. To have urethral injuries per se in isolated case is difficult, very rare. Okay, for this case, basically this patient presented with impaled object at the left inner thigh, and then he was removed from the metal object and brought into ED after 3 hours post-trauma, complaining of blood from the urethral meatus. Okay, usually we have a case with a urethral injury in polytrauma cases, right, which is more towards blunt injury. Okay, I think what we can say is we need to know the mechanism of injury, and of course, very important to relate with our clinical findings, which are the look at the vital signs, and then of course look at the blood at the urethral meatus, and of course pain during the void and pelvic instability. We are looking at this thing, and with the aid of FAST in our emergency department, basically we can rule out any intraperitoneal injury to look for free fluid in the peritoneal cavity. So far, I think Ku and Erica, I don't have any question from the participant.
I just got a message for everyone that's listening to me. The commonest cause of urethral injury, as I want to stress again, is urinary catheterization. All right, it's us when we put in the catheter wrongly. That's the cause of the urethral injury. So please, please, please make it an effort to do it correctly. Make sure plenty of lubrication. Put it gently in. If you struggle, at least ask for help rather than forcefully do it in and then cause urethral injury, because patient will come in with stricture much later and they will suffer for the rest of their life. So just remember that your catheterization, please be gentle. Yeah, that's my message for everyone. Thank you.
Dr. Ko, if in our emergency department, we got the history of urethral injuries before and we suspected the patient possible having stricture, is it then the patient presented with acute urinary retention, is it possible for us in ED to try to insert with a smaller catheter size?
Yeah. So let's say if you technically, let's say when the patient comes in AUR in the emergency department, so you have to differentiate whether this is going to be a stricture or this is going to be a prostate. All right. If there's history, young patient, history of instrumentation, you think it's a stricture, you go to a smaller size. So let's say you start at 16, you go with 14, 12, 10, 8. But let's say if you think this patient is actually a prostate enlargement, there's no history of catheterization, patient is old, you'll do a digital rectal, the prostate is huge. You actually try to go bigger, all right? So your catheter should go 16, 18, 20, 22. That's how it goes. Because if it's a prostate enlargement, the problem is prostate compressing on the urethra. So you need a bigger, more rigid type of catheter to pass through the prostate. If you use a finer one, like a 10, a 12, right? When you go to the prostate, because the prostate is big, it just crawl. It's not going to pass through. It will just crawl. So that's why you need to differentiate whether this is a prostate or a stricture. Stricture, you go small. Prostate, you go big.
Okay, noted. Thank you, Dr. Ko. If there is no question, I would like to ask Dr. Erica, basically pertaining to our case, the reason we ordered for the CT scan, I think because need to rule out other possible intraperitoneal injuries such as possible the bladder, the rectum, okay, and then basically we will review the slides ataupun the slices of the CT scan, but to comment on the air pocket, how to confirm that there is no injury to the bowel?
Well, because air pockets can either come from the bowel or they can come from outside. So when you have penetrating injury from external source, it is possible that some air is brought in together at the same time. So when I saw the air pockets, those are the two differentials that I was thinking of. And because the tract, the soft tissue tract that I showed you earlier on, it passes very near to the anal and the lower rectum region. So that was why I raised the concern. Yeah. And but when I look back at it, the sphincter and the bowel wall actually looked, they all appear very smooth. There is no signs of disruption, because usually if there is any bowel wall penetration, you would expect the bowel wall to be a bit irregular and the fat surrounding it, especially the rectum hole, there's a lot of fat surrounding it in the ischiorectal fossa. So there will be some soft tissue density or some fat stranding or some fluid in the fat. This one, the ischiorectal fossa and everything is completely clear. It's clean. So there was no secondary signs of injury. So we wouldn't suspect it based on imaging.
So it is reasonable for the emergency department basically to order for the CT scan, basically to rule out other possible injuries, and indirectly for the looking for the possible urethral injuries.
Well, if you are suspecting anything that is above the urethra, then CT scan would be the imaging of choice. Anything above the urethra, yes. Bladder base or prostate, I think is a bit difficult to diagnose on CT scan, but there are also some secondary signs that can be seen. And also the rectum, CT scan will be the best.
All right, thank you. Cool. I think there is a question at the chat area.
Yeah, question is how advisable it is to do a in-out catheterization in patient to avoid injury, because sometimes in-out catheterization has been ordered to do up to 3 days. Actually, if you are trained to do a proper in-out and there is no prostate enlargement, you want to do an in-out, you actually can just use a smaller size catheter, plenty of lubrication. I think the biggest problem is lubrication. We always stinge on lubrication. There's a lot of pre-packed lubrication. It comes in either a syringe or a nozzle where you can just pump it into the urethra and pump all the catheter in. All right. And there's no problem with doing it because some patients are on lifelong intermittent catheterization. So that means they are doing catheterization every 4 hours for the rest of their life. So 3 days is nothing compared to rest of their life. All right. So as long as the technique is correct, plenty of lubrication, aseptic technique, and the catheter that you use is not too old. All right. Best is silicone. If you don't have silicone, at least the Foley is okay, but it's new, not too old. I think the risk of injury is very low. But the main thing is lubrication. It's the lubrication that we always stinge on it, and that's the one that's going to cause problem. I hope I answered the question, Rosalie. Yeah.
Okay. All right. Cool. For this patient, basically, he will be on as a SPC until the urethral repair. True? Correct?
Yeah.
So basically, how do you? I just want to know, how do you explain to the patient regarding the SPC care?
Oh, actually, SPC care is very simple. SPC, right? Usually, after you insert, we keep the catheter a little bit longer, 4 to 6 weeks. After 4 to 6 weeks, usually the tract matures. So when the tract matures, every exchange of SPC is actually very simple. It's much easier than you put a CBD exchange through a urethra. I mean, in male, female is easy also. In male, it's much harder to change the catheter compared to a SPC because SPC tract between the abdomen to the bladder is very short. It's only like maybe about, I don't have the measurement, it's probably about 1.52 centimeter. That's all. So it's actually very easy to change. So what the patient needs to be careful is just to be careful with the catheter. If there's any discharge from the wound, they have to seek treatment. If they're cloudy urine, if they are asymptomatic, what they do, drink a lot more water, change the catheter, and that's fine. There's nothing very difficult to take care of SPC as well. Yeah. The only problem with him, because he's a construction worker. So the issue with a construction worker is taking care of the catheter when they are working. That he's probably needs some time to adapt to it because they'll be sweating, they have to move things, they accidentally dislodge the catheter, then they have to come back to what they call it, to the ED and then change again. So yeah, but technically the tract will mature within 6 weeks. After that, the tract is actually very stable. Of course, you cannot go without the catheter for a long time because all your muscle will contract by then. So let's say you remove your catheter, you have to immediately come to emergency department. If you leave it for like 2 days, 3 days, right, your muscle all will contract, the tract will close already. Then you have to put in a new catheter.
Oh, okay. All right. And based on your experience, Gu, how many of the patients with urethral injuries develop the complication, either early or delayed?
Sorry, I didn't get a question.
Based on your experience, okay, how many of your patients with urethral injuries develop early or delayed complication?
The most common complication is stricture from urethral injury. So technically, stricture is the headache to manage because you need to do urethroplasty. I mean, a short segment stricture, usually we can just do either a dilatation or we can just cut it off. But of course, that outcome is not as great as a proper urethroplasty because when you cut a scar tissue, then the scar tissue develop back, the stricture will come back. But a proper urethroplasty, it will be done very nicely. Then you can anastomose the thing. So the problem is finding good people to do urethroplasty. Not that many number of people who actually do good urethroplasty. Yeah. So patients will actually suffer with strictures and all these things. Then the problem with all the other associated injury will be incontinence. So sometimes they get stress incontinence. When they cough, they carry heavy lift, they leak urine. That's also another problem. But it's not that common to have all this like traumatic, what I mean is like MVA type of urethral injury. The most common that we see is a catheterization type of injury, which is usually partial injury. They are not a complete injury. Yeah.
Okay. I think there is no more question.
Yeah, I think there's one more question.
Uh-huh.
Question is, can urinary catheter cause encrustation if put in too long? Any other long-term complications? I guess, yes, if you do not change your catheter long enough, it's not really about encrustation unless you have risk of stone formation. If not, what happens is if you use a latex catheter, the catheter will become hardened because of the compound of the latex. So when it becomes harder, it will cause a lot of trauma to the urethra when you try to remove the catheter. So it causes a lot of bleeding. So usually for latex catheter, we don't advise more than 2 to 3 weeks. You're supposed to change it. But silicone, because the compound can last a little bit longer, usually we can go up to a month. But that's also not a product exposure date. Even the product, they say within 2 to 3 weeks you need to change, but it's difficult for some patients. So usually we can go up to a month, sometimes up to 6 weeks. There will be some catheter that the company say can go up to 3 months, 6 months. I will usually not advise that because I don't want to wait until 3 months later, the whole catheter is stuck to the urethra, then only we remove, then it cause a lot of bleeding. So usually within a month or 6 weeks, I would advise to change. Whether there's other long-term complication, yes. Every time we move in and out the catheter, there's always risk of stricture. Long-term catheterization will have risk of infection. But sometimes best is always not to have a catheter. That is the best. So we can find a solution, we remove the solution, we don't put a patient on catheter. The only problem is some patients will have no choice than to have a long-term catheter, then we have to do preventive measures. Yep.
All right. I hope that your answer, Dr. Koo, will help with the person just now asking the question. Okay, I think the time is up. And
boleh kita share slide untuk CPD point sekarang?
Slide.
Saya sharekan
Boleh. Terima kasih
Lepas
Dr.
CPD point ni kita ada kahut Sekarang ni kita dah kesetukan masa. Saya share CPD point, lepas tu saya share kahut
Okay, thank you Dr. Erika, Dr. Koo and Dr. Nakib for a good presentation and very informative presentation. Okay, see you all later. Bye.
Thank you.
Thank you.
Thank you.
Thank you.
Untuk makluman, barcode di bahagian atas tu adalah untuk kehadiran itu untuk ISPEL. Barcode di bahagian bawah tu untuk doktor sahajalah. Menggunakan apps MMA Yang atas tu untuk semua, untuk everyone, untuk panelis sekali dan juga semua kaki tangan UKM sahaja. Yang bahagian bawah tu adalah untuk CPD point untuk doktor sahaja. Menggunakan MMA apps. Terima kasih.